Good afternoon. If you would please take your seats. It is indeed a matter of great honor and privilege for me to be introducing to you one of my dear friends. I call him my younger brother, Jeremy Freeman. Jeremy's name in the thyroid world is not only a household name in North America, but all over the world. Dr. Freeman, I should say Professor Freeman, was the chairman of the Department of Otolaryngology at Mount Sinai Hospital in Toronto, and currently holds the Tammy Lettner Diana Care Chair in Head and Neck Oncology. If I were to take and even cite some of the prominent accomplishments of his, I would have taken a substantial part of his talk, so I will be very brief. Jeremy serves on numerous editorial boards, has one of the leading head and neck fellowship program in North America. He personally has trained over 64 fellows, 200 residents, and numerous observers and visitors. Jeremy is not only a scientist, having written 273 peer-reviewed papers, but is also an organizer, fundraiser, philanthropist, and needless to say, a master surgeon. He established and coordinates the endocrine team at Mount Sinai Hospital. And I must say that with his own personal philanthropy and having raised funds, has established the Freeman Center for Endocrine Oncology at Mount Sinai Hospital. His work in thyroid surgery is well known, and his technical expertise in thyroid operations is second to none. Again, I can go on, and I didn't want his head to swell, so I will stop here, but it gives me immense pleasure to introduce to you my dear friend, scholar, scientist, surgeon, and a gentleman, Jeremy Freeman.
Thank you very much, Jay. It's an honor and a pleasure to have been chosen by the steering committee to give this keynote lecture. And I've actually realized one of my childhood fantasies, and that is to be introduced by Jayton Shaw. So thank you very much. I have other fantasies too, but that was one of them. So that's me. What is the definition of a keynote? So the Oxford English Dictionary says it's establishing a prevailing tone or a central theme. And that's what I want to do. And I'm going to include surgery, and I'm going to include recurrence as given to me by the steering committee as an assignment. But I'm also going to, I said, what the heck? I'm going to talk about the whole breadth of thyroid oncology. And I'm going to be kind of on a dark side here, because I'm going to tell you what not to do rather than what to do. So this is a bit of a departure from the usual addresses that people in keynotes give. So I'm going to try to give you an idea of how to do more, how to get more for doing less. And these are my disclosures. So the objective is to review the present paradigm of managing thyroid nodules and its deficiencies, and to offer an approach to correct such deficiencies and effect a major paradigm shift to benefit patients and healthcare systems. And you've heard a lot about this already. So we talk a lot about these guidelines. What do guidelines do? Well, they provide an optimal management protocol, they standardize management, and they are cost effective. And I think Brian and his group have tried to do this in a responsible way in evolving the ATA guidelines. Here are the ATA guidelines, and many of these authors are here today, and many of the authors that I'm going to refer to are sitting in the audience today. So it's this is an amazing meeting, because you can't lie very much, and also you have to give credit to the people who are sitting in the audience most of the time. So there's two terms I want to use. One is binary, and binary means yes or no. End of story. And I want to talk about things called de-escalation. And de-escalation, according to the Oxford English Dictionary, is the reduction of the intensity of a conflict or potentially violent situation. So I've identified 7 troublesome areas in patients who have thyroid cancer and how we deal with them. There's the pervasive use of inappropriate ultrasound, liberal approach to needle aspiration, more extensive primary surgery than necessary, the liberal utilization of prophylactic central neck dissection, extensive application of RAI, aggressive approach to central compartment and perhaps lateral compartment, and too many surgeons operating on too few cases. I'm going to briefly address each one of these issues. So number 1, I was made aware that this is, and we've all seen this curve of the incidence of thyroid cancer, which is exponential, but the death rate remains steady. This is the classical epidemiological curve of overdiagnosis. And much of our overdiagnosis, I think, is due to primary care physicians sending patients for inappropriate ultrasounds. For example, patient comes to a PCP with a cough. What's the first test that PCP orders? An ultrasound. And what do we find on that ultrasound? Micropapillary carcinoma. So now, being in the brotherhood and sisterhood of narcissistic surgeons, I like to quote myself. So now we're in a situation where we're identifying more patients who may not need treatment, and we may be overtreating those patients who don't need treatment at all, not to mention those patients with treatable cancers who are already being overtreated. So the incidence of thyroid cancer, as you know, is growing exponentially. And in fact, in autopsy studies in many jurisdictions, including our province, 1 in 4, 24% of patients have thyroid cancer. Now, if you extrapolate that, say, to the United States, and I'm being a bit facetious here, whose population is 325 million, we have a cohort of patients existing of 78 million patients with thyroid cancer. Now, clearly, we can't operate on 78 million patients, but as Mike Tuttle once told me, every clinical thyroid cancer starts as a microcancer. So somehow we've got to separate the wheat from the chaff. Now, I heard a radio program on the CBC, our national radio station, talking about inappropriate testing. And what we have to do is educate our PCPs, educate people who order ultrasounds, because that's the only way we're going to get rid of this epidemic of micropapillary carcinoma, which many of us don't know what to do with. So we have to tell patients and also their physicians to answer 4 questions. Do I really need this test? I'm having trouble seeing it. What are the, what are the downsides? What are the other options? And what happens if I do nothing? And this is going to get rid of this problem if we can educate these people. What about liberal approach to fine needle aspirate? Well, the ATA has been very good at defining parameters on which nodules to operate on. And we've separated those nodules which are purely cystic. We've separated those small nodules, if you read the guidelines very carefully. And we've also developed a risk strata or risk stratification for these nodules and which ones not to intervene with. Now, one of the things that we really need to do is do a binary approach to these fine needle aspiration result reportings. And the Fagan group in New York and Yuri Nikiforov's group have started us on this road. And it's a train that is unstoppable, because what's going to happen eventually, and Yuri was up in Toronto giving us this lecture, is these molecular tests, I think, are going to give us a binary answer, and they're going to supplant the reporting of cytology. So in the future, I see this in the next 5, 6 years, 8 years, is we're going to perhaps use cytology as a complement to molecular testing as a decision-making tool to operate or not operate on patients with thyroid cancer. And Yuri's formulated a whole slew of combos to determine the incidence or the relative incidence of thyroid cancer. And this is a slide that really kind of blew me away that Yuri allowed me to present here. And if you look very closely, you'll see that the chance of picking up thyroid cancer by his combo of testing, oncogenic testing, is exceedingly high. And he's done about close to 5,000 patients and reported these results. Now, if these results are reproducible, and if these results are valid, and if the cost of this molecular testing comes down somewhat, I think we're onto something. And I think this is an inexorable pathway that we should be on, and will give us a more accurate determination on which patients to not operate upon. What about more extensive surgery to the point of this talk? Well, I loved Ernie Mazzaferri. Ernie and I were very good friends, but I think Ernie set the standard for management of thyroid cancer that it took us decades to get away from. And the Air Force study that Ernie did really told us that there were 3 plateaus in treating thyroid cancer. You operated on these patients, you gave them all radioactive iodine, or most of them radioactive iodine, and then you followed them. End of story. Well, we don't do that nowadays. I only do 2 thyroid operations. I do a subtotal or hemithyroidectomy, and I do a total thyroidectomy. Now, what are the logical reasons to do a total thyroidectomy? Well, you want to maximize outcomes. You want to aid in the technical aspects of the operation. Sometimes it's impossible not to do a total. You want to maximize outcomes for surgery for thyroid cancer, and you want to minimize complications. And what are the reasons not to do a total? Well, when outcomes are not affected by doing a lesser procedure, clearly, or if complications are higher, even though outcomes are the same or better with a lesser procedure. So you all know the reasons for doing a total thyroidectomy better than me, probably. And one of the main reasons, of course, that it enhances monitoring for TG. But is that really a reason to subject a patient to possible complication? And don't forget that doing total thyroidectomies predisposes some patients to osteoporosis if they don't need to do a total thyroidectomy. And the proponents of hemithyroidectomy claim the lower complication rates. Very true. You're not required to have medication in most cases. And in the low-risk patient, you don't have to give them RAI. And there's no strong evidence to support survival or recurrence benefits in a lot of studies. Clearly, in some patients with thyroid cancer, a total thyroidectomy is necessary, such as this large papillary carcinoma, or this large obstructing lesion with a superior vena cava syndrome. And I hearken you back to the seminal paper, probably the most important paper in this arena, and this was done by Jayton Shaw at Memorial, where they did a match pair analysis and found for low-risk thyroid cancer, you don't have to do a total thyroidectomy. Jay, did I say that just like you told me? Okay. The recent paper coming out of Memorial by Ian Nixon reiterated this. They looked at a huge number of patients and found that the results of doing less than a total compared to doing a total were equal. Many papers have come out stating the same thing. And it's intuitive. If you've got a small cancer in one part of the thyroid, why do you have to risk complications to patients by taking out that whole thyroid? And again, the ATA guidelines have been very responsible, and they inserted this, this recommendation, number 35, to tell us that nodules that are less than 4 centimeters don't need a total thyroidectomy. And here it is. Although they don't tell you not to do total thyroidectomies in cases in which you think it's appropriate. So, which thyroid cases mandate a total thyroidectomy? Well, you can read as well as I can, and there's a whole bunch of them. And then there's a bunch of them that need a total thyroidectomy by virtue of that little devil that even though you have unilateral lesions, you need to do a total thyroidectomy because that whole thyroid is at risk, such as Chernobyl survivors, Filipinos, patients with strong family history, patients who've had radiation to their neck, and so on. So here's the ultimate decision. Do a hemithyroidectomy for small cancers, low-risk cancers, and a total thyroidectomy for all others where it's appropriate. Now, what about overdiagnosis? Well, how can we treat these patients? Well, we're grateful to Professor Ito for his seminal study, and he lent me these slides, and we've all seen this time and time again. And basically, many of these patients do very well, less than 1 centimeter. A small proportion of those patients require surgery, but the important part of that paradigm is that even though you operate on them later on after observation, their outcomes are no worse than patients who would have been operated on per primum. And this has been reiterated by the memorial data, and Mike Tuttle has told me now that they're following and this is soon to be published, so there's an embargo, but needless to say, he's following about 375 patients with micropapillary, and he has the same outcome results as Professor Ito. And now we've got this NIF-P variant that we have to deal with. Is it cancer? Is it not cancer? But I think Yuri will probably come up with the answer in the next 5 years about whether or not we can operate on, whether or not we should operate on, because he's going to tell us right at the outset with his molecular testing whether or not we need to do surgery. What about the utilization of prophylactic central neck dissection? Well, here's the central neck. There are 2 types of neck dissections in thyroid surgery. There's a central neck and there's a lateral neck. Now, here's a slide that Ernie lent me just to demonstrate the capriciousness of thyroid metastatic disease. A huge percentage of these nodes metastasize to the central neck. But do we really, even if they do exist, do they really need attention surgically? And there are a bunch of proponents of central neck, and you know, as surgeons, we all kind of flex our muscles and beat our chests, and we can do a central neck better and faster and more efficient than anybody, and we don't have complications. But the bottom line is there are complications to central neck, and a lot of these patients do have hypoparathyroidism. The guidelines have been very explicit, but I think somewhat falling short in terms of central neck, because if there is a central neck in a recurrent situation, the guidelines suggest doing it, and which I'll address in a minute. But the guidelines have also been very explicit in telling us that perhaps we shouldn't operate on these central necks per primum. The bottom line about central necks is there is a higher complication rate, and there's no compelling evidence that a prophylactic central neck influences outcome. No question that we should probably be doing central necks as a therapeutic procedure for extant disease, but not a question that the jury's still out on whether we should do a prophylactic one. The guidelines tell us that probably advanced thyroid cancer mandates a prophylactic neck dissection, but even then, the evidence is quite weak. What about extensive application of RAI? How can we do less or de-escalate this? Well, I bring you back to Ernie's algorithm. You just do it for everybody. And I think, and it's not nice to talk ill of the dead, and I would never do that about Ernie, but I think he was kind of wrong on this one. And we owe a lot to Ian Hay, and Ian, I think, is in the audience, for bringing to attention that not everybody needs radioactive iodine. And in many of his publications, the authors could not confirm a significant consistent benefit to RAI. And this is from Ian's study that Brian McIver lent me, and they looked at small thyroid cancers with nodes and without nodes, and they looked at recurrence and survival, and this is just one of those curves. And here are patients who were operated on and then had radioactive iodine compared to a cohort of patients who didn't have radioactive iodine. Poor souls, they were deprived of this, and the results are the same. And these curves are absolutely superimposable in patients who have N1 disease in terms of survival, in terms of recurrence. So the guidelines have been have tried to be responsible and risk stratified patients into various risk groups, and then told us that the higher risk groups mandate radioactive iodine. But what we need is a selective approach, a binary approach, where we say yes or no. And what we did in Toronto was try to formulate a binary approach where we could actually look at a formula and determine whether or not radioactive iodine is useful in a patient or not. So this is a metric that we used, and the easiest metric, and the one that's sitting right in front of our noses, is serum TG stimulated. So we know from the literature that TG measurements prior to initial radioactive iodine independently predict future stimulated thyroid globulin positivity in well-differentiated thyroid cancer. And if we look at recommendation 50, this has now crept into our awareness in terms of the guidelines, and recommendation 50 states that now we can rely on TG as a binary parameter to determine whether or not radioactive iodine should be administered or not, and it's a strong recommendation. So our group published a series of 129 patients, and what we did, and these patients were followed up to date now 8 years, and what we did was we divided them into 3 groups, and we did a stimulated thyroglobulin post-surgery, and these were the low and indeterminate thyroid, well-differentiated thyroid cancers. And here is how we stimulated them, and you can see that there's a cross-section of stimulation. There were patients who were stimulated with 5 days after surgery with recombinant human TSH, 9 days after, I'm sorry, not 5 days after surgery, 5 days after recombinant TSH, 5 days after T3 withdrawal, and 22 days after T4 withdrawal, because of T4 obviously it takes longer to get out of the system. And here we have our algorithm. We divided patients into those that had a TG of less than 1, those that had TG between 1 and 5, and those with a greater TG than 5. And we gave them radioactive iodine if they had a TG greater than 5, or offered it to them. If they had a TG less than 1, we offered no TG, and between 1 and 5, we used clinical parameters. So here are our results. These are the percentages of patients in each group, 65% in the TG less than 1, 31% in those in the intermediate group, and 4% in the ones that are greater than 5. And 1 out of 84 patient preference received TG in the less than 1 group, 8 out of 40 in the intermediate group, and 4 out of 5, one refused TG in the TGs, one refused RAI in the TGs greater than 5. So our results were that only 1 patient recurred. I operated on that patient. That patient is still alive. We have 8-year survival and recurrence stats. To date, none of those other patients have recurred. But interestingly, if the ATA guidelines were applied to that patient cohort, 57% of those patients would have received RAI. In our group, only 10% did. So we've saved those patients RAI and the complications thereof. We've saved the healthcare system the money it would have cost to give them RAI, and we've allayed patient inconvenience and anxiety. So now we have, I'm not saying this is the be-all and end-all, but now we have a paradigm on which to place our hat and determine whether or not RAI should be given or not. Now, again, in the recurrent situation, should we be operating on all these patients? Well, the ATIA guidelines kind of suggest that we should operate on all metastatic disease, and we've formulated a paradigm where we don't necessarily believe so. We offer patients options in the appropriate situations. We can observe these things. The Italians have been doing radiofrequency ablation, and I'm not familiar with these outcome results yet, but I've been doing a lot of alcohol ablation for small tumors, a la Ian Hay and the Mayo group, with good results, and the odd patient we've been operating on again for central disease. Now again, Dr. Ito has defined for us the biological behavior of thyroid cancer. And, you know, I always have this discussion with patients. I tell them, you know, thyroid cancer is not like breast cancer, not like colon cancer, not like lung cancer. It has low biological activity, even in the recurrent situation. And so here's a radio frequency setup, but the Norwegians actually, I think, wrote the first papers and studies on alcohol ablation, and we do that now with good success, copying the Mayo system. And the advantages are the cost, and also we're not doing big operations, and these are high-stakes operations, putting the recurrent nerve and the parathyroids at risk. And I remember Clive Grant talking to us about this and saying, you know, he hasn't operated on many failures of alcohol ablation. I have, and I can tell you that it's not that much more difficult than doing a conventional reoperative procedure. So Mike Tuttle and his group are following a bunch of these patients now as well, and I commend you to read Mike's paper with lead author Rubenstock, where they're following 166 patients with existing metastatic thyroid disease, and many of those patients don't need any surgery. So that brings us to recommendation 71, where we're told by the ATA that we should consider operating on some of these patients. Now again, we do two operations. There's the central operation and the lateral operation. And clearly, in the old days, when I used to operate on everybody with central recurrence, such as this patient, clearly I don't think we need to do that at this time, although a lot of central recurrence, such as in this patient with an invasive central node, which we could see on bronchoscopy, needs surgery because she's going to be in one heap of trouble pretty soon. Now, I've done 270 of these reoperations. In a 17-year period, I've had a 1.3% vocal cord injury, and I've had permanent hypoparathyroidism in 7%. And I'm not sure about other studies, but I think these figures are about as good as you get, considering the field that we're operating on. And we've normalized TG in about 55% of patients. But again, I think we're overdiagnosing these patients, and I don't think we're in the old days, if I apply our criteria now to those days, I don't think we needed to operate on a lot of those patients, admittedly. And what I'm going to do is I'm going to look back at these patients and apply these criteria and see if these patients really would have had surgery nowadays. I suspect not. And finally, I want to talk about a thing that might be very sensitive to many of the people in the audience. And some of you folks may hate me for this, but it's okay. I work in an academic tertiary care center, and I'm used to that. So there was a study done in surgery in 2003, and Dave Terrace was kind enough to send me this paper, which I read, and there was one quote that I found very interesting. 50% of patients who undergo thyroid operations have them performed by surgeons who do an average of 5 or fewer of these operations a year. So I think what we've got to do is de-escalate this as well. I'm happy if surgeons do surgery and make a lot of money, but in our province, what we've done is we've got an overseeing body of surgery done in many of the centers. And if you're not doing a volume that's critical to giving patients their optimal chance of a good outcome, you're not doing that surgery anymore because you're not going to get paid for it. And perhaps that is the way to go. We need an overseeing body because truly, to all the surgeons and the endocrinologists in this audience, if you had a family member who had thyroid cancer who needed surgery, would you send that family member to a surgeon who does less than 5 a year? And I know what the answer is. So at the end of the day, how do we deal with these pervasive, troublesome areas? Well, the ultrasound area needs education to the PCPs. The liberal use of needle aspirate needs education, dissemination of the ATA guidelines, and perhaps development of molecular tests a la Nikiforov and Fagan. How do we deal with more extensive primary surgery than necessary? Again, it's all education and development of molecular testing that will dictate what operation we do in a binary way. The liberal use of prophylactic central neck dissection, again, education. You see what the operative word is here. Extensive application of RAI. We need to educate our endocrine colleagues. Aggressive approach to central compartment and perhaps lateral compartment. Again, educating. You can see where this is going. And then too many surgeons operating on too few cases. I think you all in the United States probably need an oversight body to deal with this problem as it exists. So that's the end of my talk. I just want to acknowledge, as I look towards the horizon and the twilight of my career, the people who have been most seminal in developing my career, and first and foremost is my family and my community and my friends shown in that middle panel. And if Dennis Krause is in the audience, yes, those friends of mine are the Rush Rock Group. I love the steering committee, and I've had an enormous pleasure developing these meetings with the steering committee. And of course, my residents and trainees and fellows and my colleagues with whom I've had immense pleasure interacting, and my patients, and of course, the hospital that I work in and the province I work in. And of course, thank you very much for allowing me this huge honor to address you. Thank you.
Jeremy, thank you for a very eloquent and state-of-the-art talk on the role of the surgeon in thyroid cancer. As a token of appreciation from the steering committee, we have this diploma for you. Come here. You're going to hang this on the wall of your office.
Do whatever he tells me.